With that, it is now my pleasure to introduce Kristen Erickson and Katie Literate from Children's Hospital Boston. Katie serves as the Health Education Project Manager and Editor at Boston Children's Hospital. In this role, she works with clinicians to create patient and family education materials. She is also a staff member on the Family Advisory Council, where she provides communication support and recruits families to help with the evaluation of health education materials. Ms. Erickson is a certified health education specialist and a member of the Healthcare Education Association. Katie has extensive hospital and healthcare experience, both inpatient and outpatient, as well as home care. She served on the Neonatal Intensive Care Unit Family Advisory Council at Boston Children's Hospital for 2 years and then joined the hospital-wide Advisory Council in 2011. As a Family Advisory Council member, Katie serves on 21 active initiatives and projects and collaborates with patient and family education staff. I'd like to now turn the conference over to Katie and Kristen for their presentation on engaging families in building a health-literate organization. Go ahead.
Thank you so much for that introduction. This is Kristen Erickson speaking. As I was introduced, I work as a Health Education Project Manager and Editor at Boston Children's Hospital, and I'm really excited to give this webinar today. Basically, as you'll learn throughout this presentation, our dream here at Boston Children's was to really build a comprehensive patient and family education strategy that encourages both collaboration and standardization across the hospital. We began this journey about 2 years ago, and I have to say that it really could not have been possible without the support of our families, especially Katie Literate joining me today, who's been such a champion. She's a parent on our Family Advisory Council, and she will share her story with you today and also discuss why health education was integral to her experience at the hospital. And Katie also just started a new role at the hospital as a Family Partnerships Coordinator, and so as we get into that presentation, she'll tell you a little bit more about that as well. Just a little background info about Boston Children's Hospital. We have 395 beds. We are one of the largest pediatric medical centers in the U.S. We operate several satellite locations. We have satellites in Waltham, Peabody, and in Lexington and other areas. We serve kids from birth through 21 years of age. We also do provide some fetal and adult care. So we have about 25,000 inpatient admissions a year, 200 specialized clinical programs, and 557,000 visits a year. And if you want to learn more, you can follow that link that I provided for you on the slide. So let's get into the meat of this, where we began. I want to give you a little bit of background about how this role came about. I started at Children's about 4 years ago, but I was in a dual report communication role working as a communication specialist. So I was in the departments of emergency management and as well as staff development, which is now called clinical education and informatics. And at the time, I was pursuing my master's degree in health communication at Emerson College and at Tufts University School of Medicine. And my coursework focused closely on health literacy and plain language writing. And because of this education, my manager, who was in clinical education and informatics, had pulled me in to help with our family education materials. And at the time, there wasn't really a formal family education program. It was managed by a part-time program coordinator and a social worker in our Center for Families. And basically, these were just health-related family education sheets. They were one-pagers, or in some cases, many of them were multiple pages, about home care instructions, conditions and diseases, procedures and tests, etc. And so as I became more involved in looking over these family education materials, I noticed that there was a lack of engagement of the end user in the creation of the material. And so this kind of sparked an idea for me, and this is in the journey that we're kind of on right now to being a health literate organization. So to jump forward a little bit, where we are now is I, for the past year, have now assumed a position as a full-time project manager and editor devoted to patient and family education, as well as working with our patients and families on the Family Advisory Council. Family education now falls under clinical education and informatics, which is nursing and patient care. And we're incredibly fortunate to have hired a full-time graphic designer and a part-time medical writer. I'll talk more about this on the later in the presentation, but it's really been integral for our program. And part of the vision for me is really expanding beyond those family education sheets. I think health education is a lot more than just handing out patient education materials, although that is central. But we'll learn a little bit more about other initiatives that we're working on. And most importantly, I think it's been great that we've been able to engage a committee of 10 or more families to review our materials. And so I'm going to turn this slide over to Katie, who's going to talk to you a little bit about how we engage our families at Boston Children's.
Hi, everybody. So again, like Kristen mentioned, I'll speak a little bit more to my own story and journey in the slides coming up. But currently we have several different ways that patients, families, family members can give back to Boston Children's Hospital. One of those is the Family Advisory Council, and that's the council that Kristen mentioned earlier. It's a committee of about 20 parents. It does not have to be a parent. It can be a guardian or a family member, but currently it is a parent-centered group. We meet monthly and discuss initiatives in the hospital, and our mission is to enmesh ourselves as much as possible into every and any decision made at Boston Children's Hospital. Now, obviously, that's pretty impossible, truly, but we have found that through the people we interact with and collaborate with at meetings, to the committees that we serve on, bringing the patient and family perspective to those meetings, that we actually have been able to really, really expand our reach. And we are involved in a lot of, even at the executive level, we are involved in a lot of the decisions made in and around the hospital. And that has to do not only from the administrative standpoint, but also the care standpoint. Family-centered rounding is something that Boston Children's put into play a few years ago. It's been honestly a true challenge, but a well worth it challenge. And that is where patients and families are involved in physician rounds. They are invited to join in the discussion, to share their concerns, to ask their questions, and the intent is that there's a single point of collaboration and contact between the entire team and the patient and family on any given day. The family-to-family mentorship program is something that's ebbed and flowed from time to time based on need as well as leadership and functionality. It's a tough program to navigate, but it does pair families who have experienced similar challenges with one another. We've had extreme success in our diabetes program, the autism program. I do know that the NICU program has that as well. But that's an ongoing initiative, and understandably, when you're talking about something as emotional as your child's care, just navigating people's point of view and perspectives is probably the most sensitive topic when running that program. The Virtual Advisors Program is a new program for us. It's intended to engage a broader range of parents and families in giving concrete and constructive feedback on whatever initiatives are going on in the hospital. This could be perfect for people who are restricted on their on-site volunteer abilities by either location and or scheduling. And the Teen Advisory Committee is about 20 teens. They range from freshmen in high school to senior in college. It is mentored and coordinated by 2 staff members, but is completely driven in decisions and initiatives by those adolescents. Family coordinators is actually a position that I just took over, and we're hoping to welcome a few more on. And we are really the more on-site, on a regular basis, patient and family voice. We work on projects, we sit in meetings, but I like to tell people, please ignore that I have a badge or that I receive a paycheck, because I'm really here as a parent.
Great.
So my story, this picture was my daughter's 6th birthday. They are now 7 and a half. I'm lucky to be married to Paul, who's on the right there, and we welcomed our identical twin daughters, Sophie on the left and Madeline making the silly face in the green t-shirt in the middle, on July 6, 2008. They were born very unexpectedly. At 27 weeks, 1-day gestation, we were living in New York City at the time. I had had a high-risk pregnancy due to the fact that I had identical twins, but I was monitored regularly, and everything was going pretty well. So lo and behold, to my very large surprise, I went into labor. We still have no idea why, and two hours later, we were parents, and very, very, very unprepared parents. Sophie and Maddie did not have the benefit of in utero steroid shots to help their lungs, and both were on long-term ventilator support. They faced pretty identical challenges, except for some one-offs, and but those one-offs made a really big difference. And we spent time in New York City between 3 separate hospitals, so we were juggling kids at different hospitals for different reasons, on different precautions. We then had Sophie come home after 109 days and 4 surgeries at that point. And Maddie was finally stable at the age of 4 months, and they looked at us and they said, "We know you're looking to relocate to Boston, and we could send Maddie to a rehab facility in New Jersey to just wean off of her oxygen, or we could send you to Boston." So we actually moved with less than 24 hours notice. We followed the ambulance, got the call that it was a go at 4 a.m. one day, and I believe it was November 14th, 2009. We moved from New York City to Boston, and Maddie was transferred by ambulance due to her respiratory illness and requirements via ambulance and not by med flight. So we got here. We spent another few months, another few surgeries, and Maddie came home with a feeding tube, home oxygen, round-the-clock home nursing care, and was an extremely sick baby at 199 days of life. Unfortunately, 7 weeks later, she developed acute pulmonary hypertension, which threatened her life again. She came back, was readmitted to the NICU, and we spent another 6 weeks here. So we are very, very, very fortunate. We've had a very long journey. My daughter Maddie just graduated from her G-tube when she was 6. She graduated from her home care nurse, who also went to school with her, when she was 6.5 actually. And my girls will both be chronic, complex care, long-term, and lifelong patients for various systems. However, per the picture, we are having a whale of a good time, and they are pistols, and I have to say, they are better kids for their experiences, and we are better parents for ours.
Great. Thank you so much, Katie. So when we wanted to start looking at our family education program to look at, how we could provide better education for Katie, for families like Katie, we kind of did a little bit of a deep dive about what are some of our threats or, weaknesses were. And I think that a lot of our education challenges are the same at a lot of other organizations. And I think the number one is the silo mentality. As you can see in this picture, we have our department, we have marketing, we have physicians, nurses, research, others, all working on patient education and doing their own thing. And people are constantly recreating the wheel in terms of different types of education. The second thing was that there really wasn't a centralized department for the management of patient and family education. Nobody really knew the process or how to create something. And then third, we lacked a clear process for making sure that everything was in plain language, culturally appropriate, utilized appropriate imagery, and most important, that the material was reviewed by the target audience. And I have to be honest that we have worked on a lot of these challenges, but we still haven't figured everything out. To be honest, especially that silo mentality. But I'll talk a little bit more about that later in this presentation. I want to give you a look at what our materials have looked like when we started this process. They were very text-heavy with no visuals. There were a lot of jargon and high reading levels. Our clinicians felt very close and, possessive sort of these materials, and that they really felt that they wanted them to be in their own words. But if you kind of look at this, like a medicine approved by the FDA for suppression of the immune system after organ transplantation, and in patients greater than 13 years old, I mean, it's just a very kind of difficult thing to understand. I think most importantly, patient education is an overhead cost. I mean, it's not something that's a cost center, but I think that what's important is that there are consequences of poor patient and family education. We know that it's higher readmissions, poorer medical outcomes, and things like that. And this quote from our inpatient diabetes nurse educator really sums up why what we're doing is so important. Jean Potter is in Medicine Patient Services, and she's a diabetes nurse educator. This was a winning exemplar from our Nurses Week, and it was a story about how an education experience with a mom from another country who did not speak English. And she used the materials that she'd been using for the past 28 years that she felt very close to and very proud of. And what happened was 24 hours after the patient was sent home, they were back in the hospital. And after an assessment, it was determined that the mom didn't understand the education materials at all and just kind of nodded her head and wasn't able to care for her child at home because she didn't know what to do. And so I'll read this quote out loud, and it said, based on my initial assessment after readmission, it was evident that the current diabetes education materials used in our inpatient diabetes program were not going to work for this mother. In my 28 years of nursing, this was my first encounter with an extreme level of illiteracy, and I identified an immediate need for the development of suitable teaching tools to help this mother learn how to manage her child's new diagnosis. I do want to mention that at Children's we have a booming international population. We have a lot of Arabic, Middle Eastern patients coming in, Spanish-speaking patients. So it's now more than ever we need to be able to make sure that we're speaking in a way that is clear and easy to understand, both in writing and speech, et cetera. And that's what we're really trying to focus on. I will show you later on in this presentation what we ended up doing for Jean. We ended up turning her diabetes materials from ones that were completely text-based to ones that were all images. And when when Jean introduced this new material using all images to the mother, she basically cried and said, I can now take care of my child with this material that you gave me. So that was such an impactful experience, and it made me, Katie and I, feel really great about what we're doing. I'm going to let Katie talk about her education experience here as well.
So education is a tricky thing because it's different for every parent, and when you put crisis in the mix, it makes it even more complicated. So I will say, and I'll finish by saying that my education about the challenges that each of my daughters were facing were absolutely critical in having them be here today. When I knew what challenges were being faced and I understood them, I could ask questions. I could challenge a doctor, and I was always nervous to do it, but I would do it for my child because that's what a parent does. And every day, I got to tell you, every time we come into Children's, somebody says it's because of you guys that your kids are here today. We worked with you, but you spoke up for your kids over and over and over every single day. And I would never have been able to do that had that not been for all the people who gave me education. And I will say what I would have liked more in my education experience was more black and white written handouts, pamphlets, something that I could take home and read over the material that was spoken to me while I was like frazzled and just freaked out, honestly, about challenges. And you can only take on so much information. But if I had had the written word to take home and look at it when I was a little bit calmer and removed from the situation, I think my education would have come along a lot quicker than it did. So I like to share a story that really this image speaks to. We were about 3 months into our experience. This was not at Boston Children's Hospital. It was at Lenox Hill Hospital in New York City, and my daughter Maddie had been on an oscillator vent for really, truly about that long, and her oxygen requirements were up at 100%. We had high pressures. I mean, there weren't any more dials to turn to support her. And the doctor set a meeting for my husband and me. And typically we had weekly meetings with our physician in like one of the storage rooms near the NICU. And this one he wanted us to go to his office. And right away that set off alarms in me. And we went and we sat down, and my husband and I are both college educated. We do see the world differently in many aspects, but when it comes to our children, we really do typically have a shared vision and a shared understanding. And there were no distractions. There was no noise. There was nothing going on outside. Nobody came in. It was one doctor talking to my husband and me. And he said the exact same words. We heard the exact same words out of this man's mouth. And what I heard was, I'm not completely pessimistic, but I'm not really optimistic. And I have to have the conversation with you to tell you that, A, there's a chance that Maddie won't make it through this, and B, there's a chance that if Maddie does make it through this, that she could be ventilator dependent for the entirety of her life. And I just froze. I couldn't speak. I just nodded. I didn't want to look at my husband. I just kind of internalized everything and just said, okay, thank you. And we got up and we walked out, and I hesitated. I didn't want to look at my husband. I didn't want to look at him. I was going to break down crying, and that was something that was just, if I started, I wasn't going to stop. And next thing I know, I hear him say, well, that wasn't so bad. And for the second time in 10 minutes, I was shocked to my core. And I looked at him and I said, what? And he said, well, he said he's not pessimistic. And I like to think about that and to share it with people, because we are two people with the same level of education and a higher education at that, who sat in the exact same room, and we heard what we went in there looking to hear. I was nervous about that meeting. I knew it was in his office. It wasn't good as far as I was concerned, and I held on to the negative, and that rocked me to my core. And he held on to the positive, because that's what he wanted to hear. So it just goes to show with education how much of a barrier parents and families have when they're in crisis, and how important it is to utilize a variety and a diverse method of communication in order to convey the same message or your message clearly to different audiences in altered states of mind.
Right, thank you. So what's the idea? What could we do to create a comprehensive, standardized patient education process that touches those who may have complex care children like Katie to those who may be here for ambulatory visits? The idea came about the concept of the Health Literate organization. Basically, it was a concept that was developed in 2012 by the Institute of Medicine's Roundtable on Health Literacy. And I really feel it could be a roadmap that can be used at every single institution. Basically, there's 10 attributes to a health literate organization. And some of the things, as you can see in these building blocks, are like plan, evaluating, improving, integrating health literacy into your planning, your evaluation measures, patient safety, and quality improvement. Designing easy-to-use materials, including your consumers, communicating effectively, explaining coverage and costs. These are really great areas to kind of start in building a program. And as most of you all know, health literacy is a problem even among those who are educated. There are about 77 million Americans who have limited health literacy, and the majority of Americans have difficulty understanding and using currently available health information and services, and people, don't feel comfortable asking questions. The beauty of a health literate organization is that it makes it easier for people to navigate, understand, and use health information and services to take care of their health. I'm going to walk you through how we're addressing some of these building blocks here at Children's as we begin our journey to being a health literate organization. The first thing that we wanted to do was include consumers like Katie. We want to include population served in the design, implementation, and evaluation of health information and services. So the first thing we did was pull together our Family Education Steering Committee in 2013. And I think what was so good about it was that it was chaired by a physician in nursing leadership. These were high-level, like VP-level people. We meet 4 times a year with multidisciplinary membership, and we have 4 families who sit on this. We're pulling together nurses, doctors, pharmacists, people from the Hale Family Center for Families, social work, marketing, telehealth, and we wanted to come together and figure out how could we standardize what we're doing. The first thing that we did when we came together was conduct a review of hospital, patient, and family education initiatives. And this was such an illuminating experience because so many people were doing the same thing. So many people were creating welcome videos to their units. So many people, we were using, the telehealth program was using Google Hangouts to kind of educate people on specific things. Katie, I don't know if there's anything else you want to say in that.
No, I think it just goes to, we would go from clinic to clinic and they'd all have their beautiful things and it was awesome. But I just kept thinking, hey, now I've got 10 handouts, so how many trees is that? And they all say similar things. But it was all with the best of intentions, and which is great.
So we figured out what could we do. So we formed some work groups, and one is a process work group. What can we create a policy around patient and family education? That's almost done. And we're going to be doing a road show where we tell everybody clinical education and informatics manages family education, and here's the process that you need to go through to be able to create your materials, whether that's videos, handouts, brochures, etc. We also formed a work group around video creation. We want to be sure that we offer education in a variety of formats, and this can be tricky because there isn't a lot of staffing to help support the creation of videos. We're creating videos on our iPhones and things like that, and I think that that's great for quick teaching, but our marketing department would love us to have these beautiful videos, but they're not able to support us in making them. So we're still trying to work out how can we meet the needs of being able to create videos. That's something that we're still doing. And then the last work group was around hackathon. A hackathon is an event that happens in the Longwood Medical area here in Boston, in which people come up with different technology-related ideas. And so, our work group met and figured out, talked about how could we create a mobile app that shares our education. We also had a nurse in the ED who wanted to create an app around home safety. So you could scan a part of your home and it would tell you you need to change your plugs or things like that. So we pulled the work group together to work on those things. The next thing that we were doing is including consumers. So I'll let Katie talk to this.
Yeah, and this really goes back to the slide about the Family Advisory Council and the Virtual Advisory Council and how we're really expanding our reach. So I'm going to be brief here, but basically Boston Children's Hospital has made a concerted effort to have not only families, but to be specific, and this is a parent speaking, so I feel like I can say this, the right families come and advocate on behalf of a larger population here in a variety of ways. And I really do feel like we are connecting the dots. So we are able to act as the go-between. In many ways, we're able to say the difficult things to the people who need to hear them because they'll listen to us because we're parents. So we can say, we really appreciate all your efforts, but I don't understand what that means. Or I think we can go a different route and get more impact. So this is a family education assessment form, and I am one of the parents who actively reviews family education materials. These are brief. Sometimes they're a couple of pages long, but as brief as can be, educational information worksheets that are provided to patients and families regarding a multitude of subjects. And oftentimes they're written by clinicians. They could also be written by other staff members throughout the hospital. However, it's truly important to have a patient family member read this kind of stuff. So, Kristen, the assessment form, it's very easy to read. Do you understand it? Honestly, sometimes I say no. I send a lot of mark back, but I want to know, even if it's a topic that I have no idea about this, I read it as if it's my child facing this. And as I'm reading through, I'll write, well, what does this mean? And what does a rash mean? And what do you mean, a type of pneumonia? I'm going to ask these questions, so you might as well put it in writing because we can then have a more constructive conversation. So it's a lot of text-based, and with the feedback that parents like me provide, Kristen then will tweak all of this stuff with her graphic designer, and we come up with some great solutions.
I have to say that this has been so beneficial, especially because some clinicians feel really, close or really protective of the things that they write. And when I look over the material or a medical writer looks over the material and it suggests a different way of saying something, they can be a little bit guarded about that. But when they hear it from the families, it's so impactful. This was just an easy form that I created based off something called the SAM, and that stands for the Suitability Assessment of Materials. It was created by some health literacy experts. It just offers a systematic way to quickly and objectively assess the suitability of health education materials for a particular audience. And it, touches upon content, understandability, writing style and tone, and design. Because at first, I was just sending materials out and saying, tell me what you think of this, and it wasn't focused enough for families. This form has really helped families focus, and it's been able to help me provide really constructive feedback back to our clinicians.
And I think the reality is if you give a parent the information that we need, you can do two things. On a positive note, you can educate them. And an educated parent is one that can engage in a collaborative and solution-based conversation with a clinician. And on the flip side, you can keep me off the internet. And we all know what's out there on the internet. But
so
if I read something and I say, I don't get it, and I didn't ask the question when I was in the meeting, I'm getting on that computer and I'm going to bad places.
Okay, thank you. That's a great point. The next thing we were doing is plan, evaluating, and improving. We want to integrate health literacy into planning, evaluation measures, patient safety, quality improvement. Because we didn't really have a formal health education program, we just had people working on materials, I wanted to conduct an environmental scan of other patient and family ed programs. So we looked at other children's hospitals. In Seattle, there's some wonderful material, there's some wonderful programs, but Seattle Children's really stood out to me as having a phenomenal model for managing patient and family education. And I actually was fortunate enough to go out there and see their program in action. And they have a wonderful model where they pair health educators up with different departments and units throughout the hospital. So each health educator may have about 10 different service lines that they're working with. And that includes helping them to update materials, create new material, make videos, and do different things. And I think they have a staff of about 5 people. And it was so inspirational to go there and see how their operations worked. It was really important. Our Family Education Steering Committee that I mentioned earlier, one of the projects that staff and families on that committee did was develop surveys to understand the patient and family education needs. We created a staff survey, and I was floored. We had over 200 people respond to that survey, and basically we asked, what their role was, what education resources that they used, the materials that they wished that they had to teach patients. And when I kind of looked at some of the key themes that came about from those surveys, the number one thing was we need to improve the look and graphic design of our materials. We have a really diverse patient population. Some people can't read. We need materials that are visual, that can teach things that can teach things visually. Another thing was materials needed in other languages. We don't have a centralized department for the translation of materials. We have interpreter services, but they don't do actual writing of or translation of materials. We have a limited amount of funds that we use to translate our family education materials into languages like Arabic and Spanish, but it's something that we definitely need to address because our materials need to be accessible in many languages. The staff also said we need to know about how to create patient family ed. We don't know how to do it. Right now we just write it and give it to people. And they also wanted to know how to find reputable online resources, which was interesting. When we also gave this survey to some of our families, and they said that they want education in a variety of ways. They like hands-on teaching as well as written and verbal instructions. They would love it if clinicians ended the visit by asking them what they wanted to learn. And then also they wanted education for children and adolescents. We have very limited education for children and adolescents. 99% of these family education sheets and materials that we have are geared towards our families. So that's something that we need to work on. And I worked, actually, I'll tell you a little bit later, but I worked with our teen advisory committee on a project around transition education. And then we also developed a review process for our education materials. There's a lot on this slide, so you can look at it in your own time, but basically it just talks about our present process and then how we are going to work on our recommended process. Something that I really feel is important is right now kind of any clinician can write materials, but I would love it if I could have some sort of health education liaison model where we could have some staff come and learn about plain language writing, and then they could kind of author those materials. I'm not sure if you're familiar, there's a wonderful health literacy expert out there. Her name is Helen Osborne. She has a great website. She has lots of podcasts. And she basically came to the hospital, to our Family Ed Steering Committee, and talked about health literacy and sort of did a little bit of a training around it. And people loved that idea and wanted to push that out to other staff throughout the hospital. And now the exciting part is how we're improving our materials. So designing easy-to-use materials. As you can see on the left, we're now using we're trying to use more imagery, more graphics to show step-by-step instructions. This PomaCort Flex Tailor sheet literally was it was about maybe 3 pages of text. Our asthma clinicians and nurses are a phenomenal team. They were absolutely willing to meet with me to work on revising their materials. We were able to take something that was 3 pages of legit just text to this 1 page that's images. And what was so inspirational is we actually brought this to families in Dorchester who have children with asthma. And we showed them the old materials and the new materials, and their eyes literally lit up, and they were like, this is so much easier for me to understand. And by the way, my child's not using the inhaler that way. So it was really inspirational. We also have tickets home. These are basically little tickets that help prepare families to complete tasks before they leave the hospital. It's a way to engage them in the process. We also use kids' health discharge instructions in our record, but a lot of that is basic. We need more complex care sort of education. That's where our family education sheets come in. And then we're starting to do more and more videos. The one that you see here is something that comes from for idiopathic scoliosis, those types of exercises. One of the best things was bringing on a graphic designer. I started by bringing in a graphic design intern, and then because there was so much work for him to do, we were able to bring him in full-time, and that has probably been such a huge impact. It's such an important place to start. You can see on the right, it says blood glucose scale. This is what our diabetes educator, who I mentioned earlier in the presentation, worked on with Brendan, our graphic designer. You could see it's almost entirely, it's all images now, and it's customizable. And basically it shows you using graphics what you need to do if your blood glucose is in a particular range. And it's had such an overwhelmingly positive response. And also Brendan is able to do comic books, and so we've been working with our hepatitis B program on creating a comic book that describes the phases of hepatitis B, and it's something that we're going to give to some of the young adult patients in that program. And he's also doing illustrations, and he also worked on a coloring book for our pre-op clinic to kind of prepare kids for their pre-op experience. And then health education and beyond in terms of meeting the needs of all. Some exciting things are happening here. We have some new projects underway in terms of utilizing interactive patient care. We are in the process of getting Get Well Network, and I think that's really going to expand our ability to take patient education to the next level. What I think is great about that system is it's a way to kind of take people through the continuum of care. You're able to also they can watch videos, and then you can ask them if they understood what they saw. You can also track, some of this, if you have specialized questions about a video that they watched, you can see where maybe they didn't understand something. So I think that's great. We're also working on improving hands-on teaching. Some things that we heard from our families on the Family Advisory Council was that the care they learn in the hospital is often not the same as the care that they learn at home. And I'll let Katie speak a little bit to that.
Yeah, I think the reality is when you're in the hospital, the syringes look different, the procedures are different, the resources are different, and when you get home, you got to learn the hard way, but you still have to get the same stuff done.
Great. We're also expanding our reach to teens in frequent flyers. So frequent flyers have been, these are people who visit our hospital often, and they say, we've been here, and now we've kind of stopped receiving education, and they want to receive education. So we need to work on that. We've also expanded our reach to teens. I did a phenomenal project with our Teen Advisory Committee. The teens are great in that they've led a huge initiative around transition of care from pediatric to adult care. They have can put together an assessment tool where that they gave to actually pediatric and adult providers that talks a little bit about how to move people through that experience. And so they created this guide called One Step at a Time. That's for young adult patients making the transition, and it just has some cool tips and tricks in there about how to have that conversation with your doctor, or how to talk, how do you know when you're ready to transition. There's some like little worksheets in there where they can write down their medications and important telephone numbers. And the funny thing is, I said, do you really want to do this as a print piece of material? And they were like, absolutely, we're more likely to use it as a booklet than as a mobile application on our phone, which I thought was really interesting, but all of them wanted a guide. Our department has also been pulled in to help with a lot of interesting projects that go beyond just those family education teams. We're working on welcome videos for our Latino families. We just released these wonderful videos that prepare our Latino families in particular for their experience at the hospital. What does it mean to be at a teaching hospital? Who are all these people that you see at the bedside? What are how are you going to prepare for your inpatient stay? How are you going to go back into your community when you're discharged home? What are some resources you can connect with? And we are working on trying to get those videos into English as well as for Arabic patients. And as I mentioned, we did a transition of care guide. We also are working on health insurance guide for parents and young adults. Our social work department has identified a need to have materials that are easy to understand to explain to our parents and young adults about health insurance and why it's important and the different options. So we worked on that. And we're also working on a major project to pull together resources for disabled patients and families. We found that we actually don't have like a comprehensive list or database or something of resources within our hospital for our patients and families who may visit that are disabled or blind, deaf, etc. And then we also have some really great future initiatives in the works. I think one of the most important building blocks that if I had to identify a goal for myself for 2016, it would be to prepare the workforce. It's preparing the workforce to be health literate and to monitor progress. Jean, who was the diabetes nurse that we featured the quote from earlier, she and I are working together on developing a health literacy competency for nurses. It's in the very early stages, but it's basically going to touch upon, how can we educate our nursing staff about what health literacy is. They're interested in there's a lot of different tools out there that you can use to assess the health literacy and numeracy skills of patients and families. But there's also a lot of controversy around using and giving those assessments to patients and families when they come in. They feel like they're being quizzed. A lot of people believe that the way to go is to use what's called universal precautions, and meaning speaking to everybody in the exact same way, without any medical jargon, etc. Everything is the same for everyone. So we're kind of working through that. We're going to be utilizing interactive patient care to assess understanding. That's Get Well Network. How can we develop specific modules, whether that be on asthma, central line care, etc., and after patients and families watch the video, maybe ask them 2 questions to to see if they understood what they saw. And then a nurse is alerted about those answers and may be able to go in and provide additional education in areas that they may not have understood. We have our surgical units working on a project around teach-back method. Teach-back is the process of, of when a doctor or nurse explains something and then asks the patient or family to repeat back what they heard in their own words. It's not about memorization. It's truly about to understand, to see if the families understood the instructions that they were given. And last, I mentioned I really want to do more of an education series. We had Helen Osborne in. I'd love to create some sort of ongoing program to teach skills around health literacy or plain language writing or cultural competency. We have a wonderful Center on Media and Child Health who have a phenomenal website with lots of resources about, parent and teen use of websites and mobile applications. I'm working with them to try and develop something around how to find resources online. Because as you remember from our survey, staff wanted to know how to find credible resources online, and the Center on Media and Child Health have a wonderful team who are really expert in that. And lastly, we are really working on ensuring easy access of our materials. Right now, they are not easy to access. Our patient and family education materials here and there are online, but not really. There's just not a lot of them on our external website. Basically, if you lose that family education sheet that you were given when you left the hospital, it's lost. You're not going to be able to find it on the website. So we want to figure out how can we get these materials to our patient portal, or how can we push them to our external website. And then last but not least, I wish there was an easier way. We have thousands of family education sheets. Right now we use a system called SharePoint to basically organize all of those materials, and clinicians are not loving SharePoint, so I have set upon myself to create a better way for them to be able to find those materials that they need when they need it. And we're also working to see, can we get these family education materials into the electronic health record? For those of you who are familiar, meaningful use requirements, you have to, you get credit if you give education based off a specific diagnosis. So we want to be able to get our family ed materials in there so our clinicians can receive credit for that. And so that's basically it, for our presentation today about how we are beginning our journey for it to be a health literate organization. It's an ongoing process. We absolutely go through, meet many roadblocks, but we're so fortunate to have a great team in place, to have leadership supporting us, and most importantly, to have family partners who just are really advocating and speaking up and saying, hey, this is important to us. This is important to our experience. And I think that has been so beneficial. And I'll let Katie wrap up as well.
No, I was just going to say that that this all seems like a lot, and some of these projects are overwhelming to me, so think about doing them and taking them on. But even some of the small things can make it a qualitative improvement, not only to patients and families, but also to clinicians by removing some of the burden of education from their shoulders.
Great. And for those of you who want to learn more about a health literate organization, I've included a reference at the end, and then you're able to kind of look up and find this particular white paper that the Institute of Medicine wrote. I think it's a phenomenal read, and I think this is a really easy, simple roadmap to use. You can even do one building block at a time, to help improve your health literacy, patient and family education efforts at the hospital. Thank you guys so much, and I look forward to taking any of your questions or comments. And if you want to reach out to me after this webinar, that's wonderful as well. I'm happy to talk to you. Thank you.
Thank you so much, Katie and Kristen, for sharing your knowledge and your expertise. We are now going to unmute all of the lines for questions and answers.
The conference has been unmuted.
So if anybody who has any questions for Katie and Kristen?
I want to say one thing. Somebody in a chat asked if are the teens on the Teen Advisory Committee family members of patients, or are they patients themselves? All of the teens on our Teen Advisory Committee are patients of the hospital.
but siblings are eligible to be on there as well.
Interesting. Katie, and I did have a question. How do you identify and recruit Family Advisory Council members?
Right now, well, there's two ways. Some of our Family Advisory Council members come from our own networks. For instance, I just referred somebody to who I ended up being linked up with because of having fragile children, and she does as well. And she said, I really don't have the time for the Family Advisory Council, but how about the Virtual Advisory Council? That we actually have built have welcomed additional family advisory and other family partnership members through people's personal networks. But additionally, there is a link on the on the Boston Children's Hospital website to say, I want to give back. And they fill out a brief survey, and we reach out to them and try to vet what they're actually interested in doing and what might be the right venue for those interests.
Excellent. Thank you so much, Katie. Are there any other questions for Katie and Kristen? Kristen, then I had a question about the needs assessment survey that you did. Did you send the exact same survey to staff and family members, or did you create two different surveys?
There were two different surveys that were created. One for staff was more focused on their role and the education resources they need and how they presently create materials and what they wish they had. And for families, it was just about their family health education needs and about the information they'd want from their child's visit and how do they best like to learn. So they were two different assessments.
Excellent, thank you. And how many family coordinators do you expect to have?
We're hoping to have 3 to 4 family coordinators, and we're also looking to hire a Latino-specific family partnership coordinator. Our Center for Families has a wonderful Latino program. They're actually the department that created those videos with us, and they're looking to start their own a Latino-focused family advisory council. And they felt that if they could find a family to help with that would be great. So that's in the works.
Excellent. Thank you.
Thank you.